Hey, Dr. McGough.
Good morning. How are you?
Can you let me in your office?
Who are you? I'm fine.
Oh my gosh, I have these pieces of letters.
Oh, okay. You're early.
I'm gonna run over upstairs to see if Jordan's upstairs to give me mail too.
Okay.
I have the 3 letters here,
Okay.
and then this key was on Jackie's badge. Is it a pump key? I try to Google it.
Yeah. Okay. No idea.
Choose your number.
It just opened. There's 3 letters. 4.
Yeah, there should be 3.
Okay.
Because it's Sam.
Yeah.
And yeah, that's it.
All right. No problem.
And then I'll get out of your chair.
Oh, you're fine.
You're able to share your screen, okay?
I haven't tried yet.
If not, I'll give you my code so you can find the host.
Let's see what it lets me do here. Share screen. Which one? Looks like I can share screen.
All right, cool.
I need to. Okay. All right. And here. Slideshow. I'm the only one here. I'm the only one here.
I'll run upstairs and see if you're up.
Annoy the children.
I can sit up there if you like and take attendance.
They got to be recorded.
Huh?
They do have to be recorded.
Yeah, no, I can think.
Oh,
I'll just sit. I'll sit in 2617 and I'll be like, oh, accept the motion.
somebody's signing in.
Yeah. I'll go sit up there with them.
You hang out with the young kids at the kids' table.
I can hang out with you if you want.
What?
Huh?
You hang out at the kids' table?
I can hang out with you.
Whatever you'd like.
Have a good rest of the day.
Oh, yeah.
Bye. Got your door shut?
Yeah, that'd be great. I can't tell who's in that room. I see a face.
It's McGough.
Oh, okay. I just see the top of a head. That's fine. Does my slide show up?
Yes, sir.
And see if it changed. Oh, yeah. Does the slide change?
Yes, sir.
All right.
Good. Morning, ma'am. How are you? We're doing great. How have you been?
Peggy, good morning.
Morning.
Are you on nights or are you?
No, I'm in Burn.
Oh, you're in Burn. Okay. I have a question for you. We got this key back from a fellow ID badge. Do you know what it is?
I have no idea.
Okay. It's got a funny end. Melissa Vendor gave it to me, so I thought you might know what it is.
Mm-mm.
Okay.
Yeah, I don't know what that is.
In that case, I may file it. permanently.
That sounds like a great idea.
I was
I have Dimitri Laurent. He's one of the neurosurgery upper level residents.
no, I don't know him.
He texted me over the weekend and says he has a medical school classmate that's interested in CCM and wants to come back to Florida. So I'm going to talk to him tonight. He would be for 2022.
Okay, well, great.
Yeah.
Anything I can do, let me know.
Yeah. Anesthesiologist at UT.
Oh. Which UT? Aren't there a bunch?
Houston. You're correct.
I can't. Franklin's not on. I'd make fun of Texas if Mike Franklin was on, but he's not on yet. Don't worry. After I make fun of Texas, he'll make fun of Michigan or something else. So.
Yeah. Well, that's easy to do. So,
I think there's more things to make fun of Michigan for than Texas.
We know it's a giant target. And we won't discuss football today. Not after the weekend. All right. It is 6:30. We all have OR and ICU things to do after this. So why don't we get started? 2 weeks ago when I spoke last, we talked about vasopressors, so things that make your blood pressure go up. Today, we're going to talk about antihypertensives, so things that make your blood pressure go down. So the yin and the yang of blood pressure control in the OR. I have no conflicts of interest. So our goals today are kind of understanding the different options for acute IV hypertensive therapy and to try to compare some of the pharmacokinetics and at least a little discussion of the cost of all of these different agents. This is not going to include oral antihypertensives. I am not going to discuss chronic management of high blood pressure. That is a huge topic, completely different set of drugs and goals. So we are really only going to discuss hypertension in the operating room and acute management of hypertension, not any of the long-term, not why ACEs and ARBs are better for long-term management, Windet, hydrochlorothiazide, all of those things which are important for long-term management, but that's not what we're going to talk about today. So in the operating room, like we talked about 2 weeks ago, blood pressure disturbances are extremely common. Acute changes in blood pressure often require acute interventions. You can't wait for the pill to work. You need to fix something relatively quickly. So to do that, we need IV medications. Fortunately, in ORs, we have IVs in everybody. And because of the rapidly changing needs and conditions of the patient, the pharmacokinetics of some of these drugs is really important. So using a medication that works, that has a 20-minute or 45-minute half-life is not a great option when you need something that's minute-to-minute control. So back to the fact that we all slept through pharmacokinetics, but it's coming back because it really is important to remember the kinetics of these drugs is really important when you choose what you're going to do. Couple of general comments. This is more outside the cardiac realm, but before initiating IV interventions, be sure to search for precipitating factors. Hypoxia, hypercarbia, light anesthesia, pain. The surgeon just did something that's extremely painful and made an incision or split a sternum. All of these are a few things to look for. You shouldn't be treating these with antihypertensives. You should be treating them with appropriate management for anesthesia, airway manipulation, changes in ventilation, whatever. All of our general anesthetics and probably all of the sedatives we use can cause hypotension. So be really careful about suddenly changing the depth of your anesthesia and then adding antihypertensives. So remember the propofol, diprivan, forane, isoforane, all of those things are antihypertensives, and it's really important to be careful when you mix and match those with the IV meds we're going to talk about today. Some other things about blood pressure, we talked about this a couple of weeks ago. Blood pressure can be expressed as systolic, diastolic, or mean. Probably mean represents, at least in the operating room, an acute situation, the most physiologic target, but we have times when we want just 3 numbers on top or less than 100 systolic. Different targets are used for different patients and in different situations. The blood pressure you want when they do aortic cannulation is different than the blood pressure you want after induction when you're going to be spending 45 minutes or an hour putting in lines. So, there isn't one goal. The goal varies. The goal varies by patient, by situation. So you have to think through what's in front of you at the moment. If you're going to use continuous vasoactive infusions, not just a chronic hypertensive that needs 1 dose of labetalol, you're probably going to need an art line. And this comment is mostly for cases outside the cardiac OR. In the cardiac OR, everybody gets an art line because they become non-pulsatile on bypass. But if you're thinking about other places, other cases we're doing, you're running nitroglycerin for blood pressure control. If you're running clofazimine for blood pressure control, you probably need an art line in. These are potent drugs that can cause sudden changes in blood pressure. We'll start with drugs that can be used as a bolus, and we'll talk about drugs that we use as infusions. Labetalol, hydralazine, metoprolol, and Vasotec are the commonly used bolus drugs. Nitroglycerin is on this list because even though it has a very short half-life, it is commonly used to acutely lower blood pressure for a brief period of time. As we call it, a stick of nitro, so a 10 cc syringe drawn out of the bottle, is a great thing to have around if you need to acutely drop blood pressure for aortic cannulation or something like that. Esmolol is the shortest acting beta blocker we have, and for acute management, it may work as a bolus, and we'll talk about esmolol specifically later. So for bolus drugs, labetalol. Labetalol is available IV or PO. Some of your patients will come in on PO labetalol. It is not one of the more common PO drugs. It's alpha to beta blocking ratio. So does 2 different things. It is a beta blocker, but it has some alpha blocking effects. So it is a vasodilator in addition to a beta blocker. That's one of the reasons why a lot of people like it. Its alpha to beta ratio, though, is roughly 1 to 3 for oral medications, but 1 to 7 IV. When you're converting from oral to IV, remember that, because if you've got somebody an oral agent and you give them the same milligrams, you're going to get a lot more beta effect and a lot more bradycardia. We take advantage of that because in general in cardiac surgery, we like the bradycardia. So the much higher beta to alpha ratio in IV form works very well. Its half-life is fairly long. Its IV half-life, according to the package insert, is somewhere in the 5.5 hour range. This makes it a tough drug to use as an infusion. You do see it used as a continuous infusion in the ICU on occasion, especially for patients with type B dissections. We're trying to control their blood pressure. We like the beta, and even though it's a 5.5 hour drug, using it as infusion for that situation probably makes sense to avoid the ups and downs. The flip side in the OR is, with that long of a half-life, if you give it, you're going to be left with it for a long time. It is not a great drug if you want to drop the blood pressure for aortic cannulation or drop the blood pressure for just a few minutes while something else is going to happen. Outside of cardiac OR, it is one of the most commonly used antihypertensives. It is really easy to reach for a bottle of labetalol and give 5 or 10 milligrams. Great drug in the operating room, especially for people on chronic beta blockers. It is great for rate control. Bolus doses are, 5 to 10 milligrams. The anesthesia dose, 1 cc, is 5 milligrams. Its peak effect is relatively quickly, so you can redose it frequently. Just remember, it's going to be around for a while, not minutes, but hours. And like I said, occasionally it's used as infusions in the ICU, mostly in the specific case of dissections when we need both beta control and blood pressure. Hydralazine, as the other bolus drug we're going to talk about, is a direct arteriolar dilator. So it's a unique class of drug. It's not alpha, not beta. It does not work through the adrenergic nervous system. It is available PO or IV. You will not see a lot of patients on it PO long term. We tend to use it as a 3rd or 4th line PO drug when we're converting difficult to control hypertensives. The unique kinetics of this drug is its peak effect is somewhat delayed. Its peak effect can occur up to 20 minutes after you give it. Now, that doesn't mean you don't see an effect much sooner. You do, but the amount of the effect will increase over time. The book says 20 minutes. It's probably a little bit shorter than that, but be careful about frequent dosing. Again, what you see at 5 minutes may not be what you're going to see 10 or 15 minutes later. And if you've given a second dose, you may be trying to get it back because you're in trouble. Half-life, again, is relatively long. You're not going to see us use this in the cardiac ORs a lot because of this long half-life. The reflex tachycardia may, in susceptible patients, be significant. It does not have beta blocking effects. So in people where you're really worried about their heart rate, this may not be a great choice, but it is a reflex tachycardia, not a direct effect. So beta block patients tend not to have that tachycardia. Bolus dosing, somewhere, again, around 10 to 20 milligrams as a bolus is a reasonable choice. Nitroglycerin is a primarily venodilator. It has arterial dilating effects. It seems to have this unique property that it dilates coronary arteries and is the go-to drug for acute coronary ischemia. It decreases both preload and afterload. It is really a short-acting drug. Its half-life is, again, in the 2 to 3 minute range, which is perfect for situations where you want to acutely drop somebody's blood pressure for a brief period, like during aortic cannulation, or while you're waiting for something else to happen, or just to get you through until you can get the anesthetic deeper. Bolus dose of nitroglycerin is about 100 mics. It is a problem in people with elevated ICP, not common in the cardiac OR, but in the neuro room. And on the test, the ICP can be a problem. Esmolol is a short-acting beta blocker. It is primarily beta 1. If you remember from 2 weeks ago, we talked about beta 1s and beta 2s, and the beta 2s are the ones that are associated with bronchodilation and arterial dilation. Because this drug is primarily a beta 1, it is okay to use in asthmatics. It is the shortest acting beta blocker we have. Its half-life is roughly 8 to 9 minutes, depending on who you read. The package insert recommends you give it as a bolus and then an infusion. And every time you up-titrate the infusion, you give an additional bolus. That's what the package insert says. It's not how most people practice. You can do this as a single bolus injection, see what the heart rate does, and then make up your mind later. So it's, a lot of people will do that for cases where they want acute heart rate control, but they're not sure they want something hanging around for a very long time. It is much better at lowering heart rate than at lowering blood pressure. So if it's a high blood pressure problem with tachycardia, labetalol is a better choice. Bolus dose is about 500 micrograms is the dose that's recommended, and that's probably a reasonable dose. Remember, you can give some and then give some more. You can't take it back. Metoprolol is another beta blocker that we use commonly. It is an inexpensive IV beta blocker. Again, it is primarily beta 1 or cardioselective as it's called, so it is effective. It is fine with asthma. Compared to esmolol, it has a much longer half-life. This is in the 3 to 7 hour half-life range. Very rapid onset. So you give it and you will start to see a drop in the heart rate within a couple of minutes. Its peak effect may be delayed up. The book says 20 minutes. I don't find it nearly that long. And again, it is great for heart rate control. It may help lower blood pressure some, but as an antihypertensive, it is not a primary drug. You can give bolus doses. Usually, the book says 5 milligrams. In the OR, I tend to give 1 to 2 and see what it does, and then repeat it frequently if I'm just trying to get heart rate control. A 5 milligram bolus dose under general anesthesia, even though that's what the book tells you, may be a bit high, and you don't want to do that. Vasotec is the only IV ACE inhibitor available. So it's really thought of as you have somebody taking an ACE that you want to continue, but you don't have gut access. It is not generally used for acute blood pressure control, but you have to remember that it's out there. So it is the only IV ACE inhibitor currently available. It has a very long half-life like the other ACE inhibitors. Its peak effect, according to the books, is somewhere in the 3 to 4 hour range, like the PO form of ACE inhibitors. Its starting dose is recommended as 1.25 milligrams every 6. You can, once you get up to 20 milligrams a day or 5 milligrams every 6, you tend not to see any additional effects. I put this in here for complete list. This is not a drug for acute blood pressure control. This is a drug for somebody who is on an ACE you need to continue, but you can't use their gut for some reason. In red, be very careful. ACE inhibitors are associated with severe hypotension with general anesthesia. This is probably not a drug you're going to be using in the cardiac OR very much. So let's get down to what's really important in the cardiac ORs, which are drugs for continuous infusion. Unlike the list for drugs that raise blood pressure, the list of drugs that lower blood pressure is fairly short. We've talked about 2 out of the 5 already. So nipride, clofidipine, nicardipine, nitroglycerin, and esmolol are really the primary drugs in adults that we use for blood pressure control as a continuous infusion. Don't have a lot of options here. I'm going to start with nipride, which was the drug that those of us with a lot of gray hair, I see Bruce's on, we grew up with. This is the drug that's been around the longest. It is a direct acting arterial dilator. It does not involve the adrenergic nervous system. It doesn't work on the same system the ACEs and ARBs work on. It is a direct arterial dilator. It has a very short half-life in the 1 to 2 minute range, which is great for acute minute-to-minute blood pressure control. It is light sensitive. That's why when you get nipride, it's in a black plastic bag. It used to come in a silver wrapped bag. The little amps we got had the silver paper that you used to wrap around the bag. It used to be known as the silver bullet because it came in a silver, you had to wrap it up in silver. Because of this problem with stability, even under fluorescent lighting, you do need to cover the bag once you mix it, and you have to change your bags every 24 hours. It's a real problem. This is the thing that the books talk about. At high doses, cyanide toxicity can be an issue. Everybody talks about this. I don't think I've ever seen a case of cyanide toxicity. So it's there, it is rare, you have to remember it, but it is really at much higher doses for much longer periods of time. The exams always ask about it, but like I said, clinically, I haven't seen it. Dosing nipride, it's run as a continuous infusion. You start somewhere in the 0.05-ish mics per kilo per minute. Usually you max out 3 to 5 mics per kilo per minute, so somewhere in that range. Titrate it like any other short-acting drug like Epi and Levophed. You can titrate it every couple of minutes. The book says doses over a mic per kilo a minute, more than an hour, associated with cyanide toxicity. I would personally say that's more than about 12 to 16 hours because, again, we've used much, much higher doses than that in the operating room for years and never seen a problem. Reflex tachycardia may be an issue in non-beta blocked adults. Again, because it's a direct dilator, it has no intrinsic cardiac effects. It is primarily an arterial dilator. It doesn't venodilate all that much. And this reflex tachycardia is variable depending on how sensitive your patients are. This, for years, was the go-to antihypertensive. Other than the fact that it was a pain in the butt to cover it in silver, and this potential risk of cyanide toxicity, it is a great arterial dilator. It is a great drug for acute blood pressure management, both in the operating room and the ICU. Its current major problem is cost, and we'll get to that. Nitroglycerin. Nitroglycerin is a direct-acting venodilator, and it does have some arterial dilation associated with it. So unlike nipride, nitroglycerin has more venodilating effects. That actually drops your blood pressure a lot if you can drop your preload. So it does have this really unique, significant coronary artery dilation. So it's really important for, it's used a lot when we do, for coronary ischemia, it is the go-to drug. For acute coronary syndromes, it really is important in cardiology in people with coronary artery disease and ischemia. That's one of the reasons lots of people love it in the OR is this risk of coronary ischemia when you're doing CABGs. It has a very short half-life. Again, it is about a minute or two. Its increase in ICP can be significant. When patients get nitroglycerin and they complain of a headache, what they're telling you is you have venodilation in their brain and they're feeling that as a headache. That's the mechanism of the headache with nitroglycerin. So in those situations where you're worried about ICP, this drug may not be your drug of choice. Tachyphylaxis with nitroglycerin, where to get the same effect over time, you have to rapidly escalate the dose, can be a problem. Reflex tachycardia, again, in susceptible patients, can be an issue. Doses for hypertension, this hospital in a lot of places dose nitroglycerin 2 different ways. We dose it on a weight-based dose for blood pressure control, and then we dose it on a non-weight-based milligram per minute dose for acute coronary syndrome and ischemia. Not quite sure why that disconnect. I've been several places where that happens, and it does. Be careful when you get a pump with nitro running, because you want to make sure if it's coming from the cardiology unit that you're not on a milligram a minute dosing, but you're on a mics per kilo per minute dosing. Just be aware that different people dose this drug differently. Dosing in the mics per kilo per minute range, 0.05 to 1 mics per kilo per minute. It doesn't necessarily have a maximum dose, but it tends not to be effective if you're pushing above somewhere in the 1 to 2 mics per kilo per minute range. If it's not working, you need to think about something else. Again, you can use this both as an infusion, or you can do, like I said, a stick of nitro is what some people call it, which is a syringe out of the bottle. That works really well for acute blood pressure lowering. Now the new kid on the block. Clofidipine is the newest kid on the block. It is a rapidly acting L-type calcium channel blocker. So it is in the same class as all those other calcium channel blockers. Because it is an L-type, it has more effect on the arteries than it does on the tachycardia. So calcium channel blockers can be used for rate control in AFib, and those are not the L-types. The L-types are used for hypertension and blood pressure control. This is the exact same class of drugs as nicardipine, which is also known as Cardine, which we'll talk about in a minute. Clofidipine has a half-life of about 1 minute. It has arterial-specific dilation, so it has very limited venodilation. It's interesting in that it has non-organ dependent elimination. So it is not, its elimination is not renally or hepatically dependent. So it is not water soluble, hence the fact it's white. It is supplied in a lipid emulsion because it is not a water soluble drug. So it is currently at this institution, the other white drug. You have to be a little bit careful. Everybody's afraid that they're going to mix it up with propofol, and actually the drug you're going to be the most concerned about is liposomal bupivacaine. So we used to look at white drugs and everybody thought it was just propofol. Now we've got multiple white drugs. Be careful. It is about 1/10 the cost of nipride. So that's why this new drug is available, because it actually economically serves replaces nipride on a cost factor. Its direct effect on the arterioles, really no venous dilating effect. It has no direct cardiac effects, but for whatever reason, the reflex tachycardia seems to be less with clofidipine than with nipride. There is no reported tachyphylaxis with this, unlike nitroglycerin, which is associated with tachyphylaxis. So how is this? Some comments about clofidipine. This is a review, and they basically talk about the ESCAPE and the ECLIPSE trials, which is how this drug was approved. And we'll talk about these for a minute. This provides great minute-to-minute blood pressure control, especially in cardiac surgery patients, better than some of the other agents we have. So we'll spend a minute talking about how this drug was approved. It was approved based on something called the ECLIPSE trials. Everybody has an acronym. I don't know who's so inventive they come up with these. I never could. So ECLIPSE is the evaluation of clobidipine in the perioperative treatment of hypertension, assessing safety and events trials. That's what they are. Published in Anesthesia and Analgesia in 2008. What this really was were 3 parallel trials, each of them comparing clobidipine to another IV antihypertensive infusion in cardiac surgery patients. So clobidipine was compared to nipride, nitroglycerin, and nicardipine. The nicardipine was only a post-op arm. We'll talk about nicardipine in a minute, why it's really not a good OR drug. In these trials, 1,500 plus patients were enrolled at 61 different places in the US. Patients had to be 18 years of age. They had to have cardiac surgery, either cabbages or valves. They did not do complex aortic. It was kind of standard cardiac or valve repair surgery. The trials that compared clobidipine with either nitro or nipride could be started either in the OR or in the ICU. The nicardipine arm was done only in the ICU. So from the safety point of view, there is no difference in safety between clobidipine and any of the comparators. By safety, they looked at death, myocardial infarction, stroke, and renal failure, and really all of these drugs have the same safety profile for these major events. What this is looking at how well clobidipine versus its comparators did at keeping patients within their, this actually looked at how often you were outside of the goal blood pressure range. So a lower number is better, is how they express this. They looked at area under the curve for the amount of time you were outside of your range, and clobidipine compared to all 3 comparators, regardless of your blood pressure goals, had more time in your range than any of the 3 comparators. The comparators are nitroglycerin, nipride, and nicardipine. So for blood pressure control, they found under the conditions of the trial that clobidipine was the best at controlling blood pressure. These numbers might be statistically significant. I'm not sure they're clinically significant, but clobidipine was shown to be better. And if you look at any one of the things they compared them with, again, time outside of your blood pressure range was lower with clobidipine than nipride at all of the ranges. It was lower, time outside your range was lower with clobidipine than it was with nitroglycerin. And it was actually, and this is the post-op only, clobidipine and nicardipine were similar until you got to the widest range. Remember, this part of the trial, because nicardipine has a very long half-life, is different than the other ones. But again, clobidipine for blood pressure control was shown to be superior to any of the other things. All right, when you talk about this, the ECLIPSE trial started at about 0.4 mics per kilo per minute, doubled every 90 seconds. It was a little bit of a complex trial in terms of that. In reality, what most of us do is we do this in mics per kilo per minute. You start at 1 mic per kilo per minute, and you titrate up from there by 1 mic per kilo per minute increments. That was the recommended dose. Unfortunately, at Shands, when they set up clobidipine here, they did non-weight-based dosing for adults for clobidipine. So it's milligrams an hour is how they titrate it. Again, if you start at 1 and go up by increments of 1, which is you start at 2 cc's and go up by 2 cc increments, that's really pretty good. Clobidipine has very low clearance during hypothermic bypass. If you're running this before you go on pump, remember its levels are going to increase when you're cold. There is no information available about changing in dosing in either renal or hepatic dysfunction, but its clearance is by tissue esterases, so we expect very limited effects. And when I last reviewed, there was no pediatric dosing information available. There hasn't been a large PEDS trial that I'm aware of. There may be one out now. It is used in PEDS, so people are using it. I just don't look at the PEDS literature very much. Again, as a reminder, it is the other white drug. The problem is this is the orange and white drug, not the blue and white drug. There was a giant to-do here by people who demanded we not get a second white drug. And at least in the ICUs, when you're using clofidipine and propofol together, there's all kinds of restrictions in the ICUs, having this concern for mixing up the white drugs. An editorial comment, how many clear drugs do we have? Yeah, so, but that's what it is. Nicardipine is a drug that I'm going to talk about because you may see people coming to the OR with it, or when you get upstairs, you may want your patients on it. Like clofidipine, it is an L-type calcium channel blocker. It is a direct arterial dilator. It is not reported to have reflex tachycardia. The problem with nicardipine in an operating room is its half-life. It has about a 45-minute half-life, so it is really difficult to titrate rapidly. And that's why in the Eclipse trials, it was not used in the intraoperative environment. This is probably not a drug you're going to want to start in the heart room for acute blood pressure control. All right, so quick comparison of these drugs. The clofidipine, nitro, and nipride all have very short half-lives. Clofidipine, nicardipine, and nipride are all primarily arterial dilators. Nitroglycerin does have that effect. The venodilating effects are much bigger in nitroglycerin. Nipride and nitro do have this potential for reflex tachycardia. And again, the long half-life makes nicardipine a problem in an operating room, especially in a cardiac operating room. If you're talking about other situations where you've got a long case and patients need long-term blood pressure control, nicardipine might be a reasonable option. Acquisition costs. These numbers are a little bit old. This is the cost that Shands pays to actually buy these drugs, and this is where it gets a little bit expensive. Okay, nipride is actually, I think, down to just under $500 an amp. Nipride comes as 50 milligrams in 2 mLs, and then you mix it up in 250. So its price hit almost $800 a couple of years ago. It is down in the $500 range. This is why we don't have nipride as a primary antihypertensive in our ORs, because every time you crack an amp, you've spent 500 bucks. It's a lot of money. So clofidipine, on the other hand, for either the 50 or the 100 ml vial, and they charge roughly the same, is about 60 bucks, 60, 70 bucks. So on a price point, this is a much better deal for two drugs that have very similar kinetics, different mechanisms of action, but clinically are very similar. This is why we use a lot of clofidipine, and why, at least in adults, nipride is not a primary go-to drug. Nitroglycerin is dirt cheap at $6 a bottle. Nicardipine, it depends if we get it pre-mixed in the bag or not. This actually works out to be significantly cheaper than clofidipine when you're talking about an entire day. So you'll often see people, once they're stable on clofidipine in the ICU, be transitioned by pharmacy, and it's a cost issue. If you're not doing minute-to-minute blood pressure control, this is reasonable. If you have an unstable patient where you are making multiple changes, you still need clofidipine as the drug you want. I mentioned esmolol before. It's a short-acting IV beta blocker. Half-life's about 9 minutes, which actually makes it kind of tough to titrate. You wouldn't think so. 9 minutes doesn't sound long, but if you're looking at 5 to 6 half-lives for steady state, now we're talking 45 minutes or so. So that's an eternity in an operating room. It does not have direct arterial or dilating effects, but it drops blood pressure by reducing heart rate and contractility. The package insert recommends a 500 mic per kilo bolus, starting an infusion at 50, and then increase the infusion in 50 mics per kilo increments with a bolus with each increase. I know in the ICU we don't dose it that way. So the bolus plus increase helps you get rapidly to a higher rate or to a higher steady state. It doesn't help on the way down. Depends on how you're using it. Again, it's the shortest acting beta blocker we have. You're probably in a cardiac OR going to be giving some boluses as well, but that's what it's recommended. And again, it takes a while to understand. 9 minutes doesn't sound like much, but in the world of infusions in an operating room or an ICU, this can be an eternity. All right, like I said, we didn't have as many things to talk about as we did for vasopressors. Are there any questions or comments or concerns about these drugs? All right, well, thank you guys very much. We'll let everybody get back to the operating room and have a good day, everybody.
Bye.
Thanks, Ed.